بسم الله الرحمن الرحيم. ده our second meeting مع 𝐂𝐨𝐦𝐩𝐥𝐢𝐚 جروب اللي احنا بنرحب بيهم معانا في شرم ديرما as usual، وهم our main support. وانا نفسي يعني بدعم وجودهم وبشكرهم جدا لانهم highly educated. السيشنز كلها الصراحه حاجه جميله. المره دي احنا بنرحب ببروفيسور اسماعيل، وهو مخصوص في الاخر هيعمل لنا الكومنتس. والمودريتور المره دي طبعا اخويا وصديقي العزيز الدكتور امين شاروبيم، وهو له باع جامد جدا في الحته دي. انا بصفتي الاولانيه لما عرفت انها على الكومبليكيشن، انا هوري الدكتور امين والاستاذ الدكتور اسماعيل يعني a lot of complication. I have a very good experience لانه هو هيقول لنا وامين معاه ازاي نمنع كل الكومبليكيشن دي، وبعد كده دول هيتعرضوا تاني في الاخر علشان تبقى الدنيا ماشيه كويس. انا هوريكم دول اكتوال دي برضو كان في قبليها، انما دي تيبيكال فورين بودي كومبليكيشن، واحنا عملنا لها بايوبسي فبروفد انها فورين بودي. بانت بعد 2 years. انا الصور اللي حوريها دي ما حدش يخاف، انا مش عايزينكم تخافوا، لكن احنا ضروري اقول لكم انها بتحصل وبعد افتر 2 years الحاله دي، وعملنا لها بايوبسي. حاولنا نحسنها مره واثنين وثلاثه واربعه، لكن ده اخرنا معاها ان احنا بنعمل الحاجات كلها حاسبها لغايه ما بروفيسور اسماعيل هيقول لنا هو مع بعض. خدوا بالكم very common complication كنا بنشوفها زمان. عشان كده انا ما بحبش، انا شخصيا رغم ان المره اللي فاتت امين اتكلم على الابر ثيرد، لكن انا شخصيا we have to take care من الانجكشن في الابر ثيرد. عشان كده الكومبليكيشن دي قلت جدا، وعشان كده برضو هنسمع من بروفيسور اسماعيل الكلام. بصوا ساعات يحصل just angioedema for 2 days 3 days. هنديها التلفاست والحاجات دي، هتلاقوا الحاجات هنقولها in details. دول بياخدوا ايه بعد شويه، بس بالمناسبه دول من جده يعني، في من هنا ومن هنا ومن هنا علشان تعرفوا انها في الاريا كلها. دي again before and after اللي بعده اهو. ديت بقى يمكن اهم صوره هعرضها، ديت الفيلر كومبليكيشن. دي كانت ليب اوجمنتيشن. العيانه كانت عندها هيربس، فحصل سيفير ديسيمينيشن اوف هيربس مع الفيلر الليب اوجمنتيشن. برضه هنسمع الكومنتس بتاعت امين وهنسمع الكومنتس بتاعت بروفيسور اسماعيل. دي اسوأ كومبليكيشن شفتها في حياتي كلها، وما اعتقدش حد فيكم شاف حاجه كده. ديت بقالها 30 سنه او 20 سنه. حقنت الاول في حته، حقنت بيرمننت كومبليكيشن، فعملت سيفير اتروفي. والكومبليكيشن بعد كده بالستيرويد، ان الراجل حقنها ستيرويد فحصل سيفير اتروفي. ودي نفس الحكايه كومبليكيشن بس ايرلي كومبليكيشن. انا كل اللي انا عايزه ان انا امهد لاستاذنا الدكتور والاستاذ امين، لانه هو خير ما هيعمل مودريتور. وانا ارحب برحاب معانا. يعني يا رب نكون
ازي حضرتك يا دكتور؟ ربنا يخلي حضرتك.
لا الله يخليك. وارحب 𝐂𝐨𝐦𝐩𝐥𝐢𝐚 بوجودهم معانا. وامين دلوقتي هسيب له المايك علشان يمشيها كويس عشان نسمع احسن كلام. اتفضل يا امين.
اهلا وسهلا. Good morning. In this fruitful Zoom meeting, I would like to introduce Professor Dr. Ismail. His lectures, I attended a lot of his lectures. His lectures are very good and are always very fruitful and are to the point and very practical for the use of fillers and all the RHA. I learned a lot from him. Today he will give us a brief presentation on the different type of complication which are common in Egypt. I had a brief with him and I told him what we see, and now we'll gain from his experience how to treat the complication and each type of complication, the common one that we see them in Egypt, and how to deal with them. Welcome, Dr. Ismail, and please, I want you to take the floor and begin your presentation. And at the end, we will discuss with Dr. Ismail some picture of the common cases of complication we encountered here in Egypt. Thank you.
Okay, Dr. Asaf and Dr. Amin, first of all, thank you for inviting me for this presentation and for this great meeting. Yes, last year I was in Egypt with you in Sharm el-Sheikh, and I saw that it was a very big congress and very well organized, and I hope next year we can do it live again, because we are doing some webinars, but it's not the same test. And it's not the same thing. We have to see each other also. I hope it will be better within the next years. These are some slides that we have to put. And as you know, this is my disclosure, as I am a part of the 𝐂𝐸𝐽𝐜 Expert Academy. I will not mention about the products of 𝐂𝐸𝐽𝐜. Generally, I will try to be on the doctor's side, and I will talk generally in complications. And so some of the complications, and most of these complications, are not related with 𝐂𝐸𝐽𝐜 products, and I have to mention about it. Okay, if you have no complication with HA fillers, then first of all, you might have a good technique. You can have a good anatomy knowledge. You have used the right products, but also you still haven't done maybe enough cases, because if you have done enough cases, one day even you are the best doctor, even you do everything right, even you use the right products, you will face the complications, I think. And also, maybe you were so lucky till that time, but one day that unlucky event can come close with you. Did I see any complications? Yes, I consulted many complications, but also I faced with my own complications. I haven't did everything right. Nobody can do everything right. And if somebody says that I have no complications, he is not doing enough cases, first thing, or he's hiding something, because if you do enough things, you might even see some simple cases, even if you do everything right. What kind of complications we have when we think about it? We might have some inflammatory things, and these inflammatory things sometimes infectious, and sometimes they are sterile. There is nothing, there's no bacterial invasion, but there is a huge inflammation. And what about what else we have? We also might have the vascular complications. What kind of vascular complications we can have? We might put some fillers to an area, and the area cannot hold that much volume and can press into the arteries. These are generally seen after rhinoplasties in nose fillers. We see these extravascular pressures, I think, and also we might have some intravascular occlusions, and directly just we give the filler inside the vessel. Okay, to give examples, this is something, there is no signs of infection, but the patient has a reaction to the filler. How we can understand it? when we send, for example, this sedimentation or C-reactive proteins, and they're not high enough, or white blood cells are not high enough, but there are reactions. And also, if we take anything with these, nothing will be cultured from these reactions. What else again? Another good example for a sterile inflammatory reaction. This is done in a beauty center. In Turkey also, I don't know the legal issues in Egypt, but also in Turkey, in beauty salons, people do some fillers also. And when we ask them what filler was done to you, they don't even know the name, and because they have no papers for it, and it's sometimes then harder to treat. If it's hyaluronic acid, yeah, we have some weapons, but if it is not hyaluronic acid, then we shall know what is the product, so we can get rid of them easily. Again, another example for a sterile inflammatory reaction. This is a very close friend of mine. I gave the filler in a very small amount, and he has the reaction. I did everything right. I used the right product. I was using a cannula, but suddenly he reacted to the product. And so these things may happen. And so we will have to have some instruments in our office that we can deal with these acute reactions if something happens. So if we are doing fillers, we shall have some thing to get rid of these acute allergic reactions also. What else in these cases? This is the malar edema. Yeah, it is mainly caused by something that we put some more volume than the area can handle. This area has a unique, as you know, lymphatic drainage system. If you give more than the area can handle, then especially malar edema becomes the case. If it is more reaction we see, then we will see more edema in the sites of these reactions. Okay, how I manage these sterile inflammatory reactions? First of all, massage, cold application, I will talk about them individually. We can apply hyaluronate to get rid of the excess of the filler. Anti-inflammatory drugs can be used. And in some cases, if we are not sure that it's sterile or it might be infectious, then I start the prophylactic antibiotics in these cases too. Okay, what about the massage? Massage is especially very, I think, beneficial for the periorbicular edema, especially if you have some devices that can do lymphatic drainage messages, like aquapeel or hydrofacials or something like that. Then I also apply the massage for those areas to make the lymphatic drainage easily. How I do the massage? I generally tell my patient that just take something, some ointments, and then just to start from the medial to lateral and then upwards. Do this massage to make the lymphatic drainage easily, but also I use some devices and my estheticians apply it also. They are beneficial. Massage are important. For cold application, I think the best solutions are these kinds of cold packs. They fit the face very well, and I think it can be done for 10 minutes in an hour or 5 minutes in every 30 minutes. Yeah, does that really makes the edema less? I'm not sure, but it makes the patient to feel more comfortable. When they apply cold, they feel more comfortable with the feeling of the edema. What about the hyaluronase? Generally, we can dilute the products. Sometimes it can come with a diluted form, but I use some forms with the powder part, and then I dilute them. According to the site, I dilute it with a 1 to 3 ml, and then apply it to the area as needed. The thing is, there is a small trick. if I will use the hydrogenase in a bigger area, I generally use a cannula, because with the cannula, I will have an easier dispersing the product and dissolving the hydrogenase in the area will be easier for me. And with needles, also, one piece, when we apply the hydrogenase, it's also painful. And with the needle, if it causes any more swellings and bruisings, the unhappy patient becomes more unhappy. And with the cannula, these risks really decreases, and maybe you can add some lidocaine. I ate some lidocaine to the solutions to make the injection of the hydrogenase less painful, because it's sometimes really very painful. And if the patient has a big problem, if he or she is still upset after the injection pain, they will be more upset. So it's very uncomfortable for hydrogenase to inject in an area. What about the systemic anti-inflammatory drugs? If the reaction is really important and big, then I use methylprednisolone for 3 to 5 days. In severe cases, I use it in 1 milligram per kilogram per day from, via intramuscular or IV way. In moderate cases, we can give it 0.5 milligrams per kilogram per day perorally in their oral form. And in minor cases, just non-steroidal anti-inflammatory drugs are generally enough. What about the local anti-inflammatory drugs? We can use local triamcinolone acetate ampoule just by diluting and giving the product into the area. If the thing is, if it's not the hyaluronic acid, if the product is not hyaluronic acid, then we have to use these products. But as Dr. Asaf showed it, triamcinolone acetate is a great product. It works well, but. The thing is, it will really dissolve our own soft tissues, and it will make the skin thinner. It will make the fat tissue in that layer thinner. So it is like a knife. Yes, it cuts the inflammation there, but also it cuts to our own tissues as well. So do not apply it directly without diluting it, and apply in small doses. And if needed, we can apply and add more. But if we add more, it really causes depressions in the areas of usage. And so we have to be careful about the product triamcinolone acetate. I dilute it 1:1 or 1:2 according to the area. What about the inflammatory things? If we can see the product just under the mucosa or under the dermis, we can directly go with a needle and just enter the area of the filler, what type of filler it is. And then by squeezing the area, we can make and we can take it out. So I also do the mechanical debridement. For example, in these kinds of cases, for the lips, I can enter directly with a needle on the area, and then I squeeze it like this, and we'll try to get rid of the thing. What about the other things? Yeah, in the past years, I really saw much of these fillers, these permanent fillers, but nowadays I see them less. If there is an abscess formation or something like that, we can directly go with a needle into the area, and we can aspirate it, or again, as seen in the left picture, we can make with a 11 blade. I can open a hole for the abscess area, and then by squeezing it, I will try to mechanically debride the product. And then if I have this product, I will send it to a microbiological culture. Okay, this is a video of mine. As we can see here, we have aspirated it, and it is a product. It's very typical. This was a reaction to an hyaluronic acid. I will not give the brand name. It's not a one. It was an old brand. It was produced in Europe, yeah, it's we assumed it as a very good filler, but it was not. And sometimes we use a product and we see the bad things after 2 years, after 3 years, and still after 8 years. Some of patients that I used these bad fillers can find me in my office and say that, doctor, you have done a filler to me 8 years ago, but I still have some reactions. Some days, some mornings I wake up and I see that my some areas are edema. I have edema.
ردي عليا من فضلك بس.
I have swellings also. So what about the prophylactic antibiotics? If I will have this culture and if I send the product to the culture, then I start the prophylactic antibiotics till the end of the culture. If the reaction is really infectious and if I don't use any antibiotics, then everything will go worse and worse by time. Generally, what I use is, as a start, I use sulbactam ampicillin or amoxicillin clavulanic acid for till the prophylactic tissue cultures I have. And after I have the tissue cultures, and if the microbiologic agent is found out, then we will continue with that antibiotic also. These reactions, yeah, this is a young lady. Again, something was done to her in a beauty salon. We do not know the product well. The owner of the beauty salon and the patient together came to me, and the beauty salon owner wanted me to get rid of these. We have debrided it, but then she didn't came to me for follow-ups. I think the beauty owner, maybe they had some also problems that will be end in the courts. Also some law issues also happened, but these reactions also can happen. So, for example, in these kind of cases, what did I do in these cases? I will send a microbiological culture. I will send something for a direct microscopy also to understand what kind of reactions, and I will contact with the user, the applier, it's a doctor or an esthetician, and I would like to learn what kind of product is, but the applicant here did not told us anything about the product, and she said that it was an hyaluronic acid, but I don't think that this product was an hyaluronic acid product. Okay, what about this? This is my own patient. She came, I did a filler. This video was just 8 years ago. No, I don't need anything. 8 years ago, I did a filler here. But now, when I see it, after 4 years, she had these reactions. This is the first time, and this is the second time. We get rid of this, but when she had this time, yeah, it was really, really very dangerous. And she was hospitalized in the department of plastic surgery for 1 month, and she had many antibiotics for her. Okay, and just a second, pardon me for the sound. And when I do the debridement, we can see that the product and the other tissues are all infected, and everything is coming. This is a horrible thing for a filler to result in. So using high quality products are very, very important to not having with these complications. Yeah, you might have some complications with even the best products. Even the best cars can do the accidents, but with using the high quality products, these risks will really decrease. And this patient really hospitalized for 30 days. It was a very hard thing to manage, even for me, because the patient always comes and asks for me, doctor, what will happen? What will happen? And after this ended, there was a depression in the area. She wanted some fillers. And in those cases, what I do, it is not logical normally to do any fillers to this area. but the patient wanted me to do fillers because she was very unhappy with the depression. Then I did some fat injections, and before the surgery, I started antibiotics 3 days ago, and I used the antibiotics for 10 days after the surgery. Yes, she was better. She didn't have any more infections, but these are risky. And if you have the chance not to do any filler to an area that is previously infected, please don't do it. Because everything is lying there, they're hiding, the microorganisms are there for the biofilms, and with a simple touch, it will start. And it's one day, once a patient came to me, yes, she had a nodule. She said that the doctor tried, it was a complication of another one. Another surgeon did hyaluronidase to the area, it did nothing. And then I tried to apply just the triamcinolone acetate, a local corticosteroid. And after it, it became infected, and I have just started the reaction, just putting a needle into the nodule. And it was like a horror, and it was not even my complication, but I have to deal with it. So if it's not your complication, yes, somebody should have done it, but you have to warn the patient that these are like bombs. If you touch them, something really might happen, dangerous, and it might lead to a severe reaction. So just know it, and then we might have some problems with that. Okay. What about severe reactions or infections? We can do the hospitalization, and we can do the debridements in those cases, and infection diseases consultation for broad spectrum antibiotic cultures. And please also, if the antibiotic cultures, bacterial cultures are not, do not have any results, also think of fungal infections and the mycobacteria infections, and you can also have cultures for them too. What about the vascular complications? Just let me. For the vascular complications, we have in some series that the estimated risks are 5 to 10 in 10,000 aesthetic applications. The range starts with the simple problems like temporary color changes and ends with blindness as the most frustrating vascular complication. There are two types of vascular complications, as I mentioned before. One is direct intravascular injection, we do it, and then it can lead to anterograde retroocclusions or retrograde occlusions. What else we have? We have the extravascular pressures. We can have vascular occlusion due to the pressure effect of the filler. Especially, this is what I see in previously operated noses. This kind of complications are really important in those secondary cases because of the fibrotic bands that are formed related with the rhinoplasty. When you inject the filler into the area, it compresses the surrounding arteries or veins, and then it will lead to some extravascular pressure changes. Okay, especially in nose area, why we have these important things, we have a system of mixture with the both internal carotis artery and both from the external carotis artery. So if we will have some injections not just directly here or around here, we can directly go here. And with retrograde injections, even we can go into the nose, into the central retinal vein, and it might even lead to blindness, as you all know. First of all, I would like to talk about the anterograde occlusions. What does this lead to? We inject anything here or anything in the dorsal area, but what in these cases we hit the supratrochlear artery. Here we can hit the supraorbital artery, and when we hit the supratrochlear artery, then it will lead to a anterior vascular occlusion in this area. Again, an example for it, that the previous case was much severe, but this is an easier one. It generally changes with redness, and then by the color changes, and if pustules are forming, then it is a more heavier occlusion. We can conclude about it. Again, this is a complication of mine. I did a nasal filler just for this depression, but it with an anterograde occlusion, it hit the tip of the nose. Yeah, it healed perfectly well. Generally, in nose, the area heals perfectly well, but if it happens, then you have to deal with that complication. So you have to know how you will deal with this complication I will mention about. Another occlusion, I think this is a one with a pressure change around all this area. Another example, I think that is also the volumetric thing. If you see some color changes, never do any more fillers in those areas. Just stop. Yeah, she healed also perfectly well. Another example, as we can see here, everything starts with the color changes, but when you start to see these pustules, and it will be worse by time, it is worse, but it healed perfectly well because the nose area generally heals very well. What about the intravascular occlusions? What shall be done? First of all, never apply too many pressure on syringe. When you're applying to an area, just apply the filler so slowly and gently. What is my trick? If, for example, I am applying the nose, I put my non-dominant hand just on the artery pathways, and so I am trying to get rid of something that might go for the retrograde occlusion. And by giving the filler slowly, then I will not overwhelm the arterial pressure, and it will not go to a retrograde occlusion. The anterograde occlusions can be solved, but the retrograde occlusions, if it goes with the central retinal vein, yeah, everything will be much more harder to fix. Try to stay, if you're on the nose, try to stay under the CMS and apply the filler just over the bone and the cartilage to get rid of those complications. If the area is too stiff, when you pinch it, you cannot pinch it, okay? Then don't do the filler. Take an eye always to the area of filling. For example, if you are doing something on lips, just I put my dominant, non-dominant hand in the arteries to make the arterial area, arterial flow less. And then when I'm applying, I'm not looking at the syringe. I'm just looking to the area that I am applying the filler. If you're doing in nose, just have your eyes on the tip of the nose, because when you have the vascular thing, you will directly see it in the moment. It will be like this. When you give the filler here, it's poof. You will see the effect directly. Just if you stop on time, you will have an easier healing process. If you continue to give it, it will be harder to fix. When an area whitens or becomes purple, never do it. Never do it. Okay, you will say that even you do a massage and it became purple and it became red again, but the patient says that, doctor, can you do it a little more? No, not in these sessions. Come after one month, we could add then. Not in this case. For the vascular occlusion, I will show you a case and I will discuss something on a case. One of my colleagues that I worked together did a nose filler to a lady according to the rules. Yes, she is quite experienced. I know that she knows doing fillers. Everything is right, but she had a problem. In theoretically, nothing was wrong. She applied in the right plane, but on the 48 hour, that is also a problem with the patient. But if a patient sends you, doctor, I have a pain in my nose till the day you applied the filler, is it normal? I always tell my patients that if you have pain, just send me a picture, a photo. The pain is not a normal thing. You might have, yes, slight pain, but if a patient says that I have a pain, always want a photo for a better look. When I saw this picture, I saw that some areas, there are red zones, some white zones, and some zones with purple things. I thought that, okay, we have some problems with that. Then I have to do something to get rid of this, and I have to call the patients. And we talked with my colleague, and then we took the patient to our clinic. This is the third day, just 48 hours after the nose filler, when she came into the clinic. We apply hyaluronidase to the area. It was the reductinase for 1,500 international units. We have diluted it with 3 ml. And we applied in total 3 ml, 1 ml in 1 hour, and for 3 times. Yes, in these situations, the patient becomes more and more anxious as you see that there is a problem, but you have to do it. So I advise you to do a local block, just doing this reductinase, because she will not let you to do the reductinase to all area if the area is not blocked, because it's really painful. She stayed at the clinic. We tried to make her nose warm with a heat source, with a lamp. And also we applied Dextran 40, that is for increasing the intravascular volumes. And we gave 50 ml per hour infusion for 6 hours. That is something that we use in our flap surgeries. If there are plastic surgeons, they know the products as well. And if you use it, then the intravascular capacities will increase. And I have started using the methylprednisolone just in the first day with IV application, and 1.5 milligrams per kilogram for the first day. And then we have just started some antibiotics for prophylaxis, and because it might be infected because of the low vascular supply. And also I applied some lansoprazole. It's for the proton pump inhibitor for the stomach, and make the gastric ulcer risk less, because in the following days I know that I will use some more steroids or anti-inflammatory things too. For ointments, I use Fusicorm cream mixed with the Nitroderm patch. Nitroderm patch, it includes nitroglycerin for vasodilatation. I'm not sure that it works, but I use it still. But in some papers, I saw that it is not assumed to be effective. But in Fusicort, it is the fusidic acid with the beta-metazone valerate for the microbial prophylaxis or for anti-inflammation. And I sent the patient to hyperbaric oxygen treatment, and he had the same session in the same day. On the third day afternoon, he had first hyperbaric oxygen treatment. As we can see here, after the hyperbaric treatment, something started to change, and after our old medication. Okay, I think some of our participants' camera is open. Pardon me, microphone is open. On the fourth day, and after the second treatment day, she had these pictures. Yeah, everything started to be setting, and the patient started to be fun. When I see these pictures, I see worse.
Sorry, Doctor. Sorry, Dr. We will unmute one of the participants. I'm sorry.
If you unmute everything, then I will mute myself again.
Yes, okay. That's okay. That's where it's okay.
Okay, you can hear me now, I think.
Yes, yes, you can.
Okay. On the fourth day, it was like that. And we applied again hyaluronidase. but we can apply it 2 times. She didn't want the 3rd time because it was very painful, and then our relations begin to be worse by the 2nd treatment day. And we again applied the dextran and the methylprednisolone again, antibiotics, lansoprazole, and again ointments. And then again to the hyperbaric oxygen treatment. Yeah, and when I saw it again, these areas are better and this area is still bad. And on the 4th and on the other day, these areas begin to be better. The patient generally panics about these areas, but I generally panic about this area, and you will see that it will be worse by time. We applied once again hyaluronase, but she didn't want any more after this day. Methylprednisolone, and now we have moved to the oral treatment, and we continued with the ointments and antibiotics and the other things, and also she had the 3rd session of the hyperbaric treatment. After the hyperbaric on the 3rd day, yeah, everything started to be better for me. When patient sees this, she is panicked, but I know that these will be better, and my eyes are on these areas. Yeah, we will have some redness here. It's going better. She did not accept it anymore, hyaluronase, and she was very unhappy. We continued with the methylprednisolone, antibiotics, and the proton pump inhibitors, and she continued ointments. We cannot give hyperbaric ointment treatment because of the weekend holiday. On that day, the clinic for the hyperbaric oxygen treatment was closed. On the 7th day and 5th treatment day, we continued these treatments. No hyperbaric treatment because of the Sunday. On the 6th filler day, 7th day of the treatment, hyperbaric oxygen treatment, she continued again. We have started. Antibiotics, we have stopped after 1 week. And the proton pump inhibitors discontinued after 1 week. And the current ointments discontinued after 5 days of treatment. She used bepanthenol combined with the madacasol after 5 days for 2 weeks. This is the 10th filler day. This is the 12th day. This is the, again, 10th treatment day. And this is the 20th day of filler. And then she became much more normal by time. Just I will mention about the blindness, some more words, and then I will finish my presentation. So first of all, just before this blindness thing, if you have a complication, please don't panic. Consult someone who might help to manage it, because if you panic and the patient sees it, she will be out of control. And if you lose time, everything will be worse by time. So the time is very precious. If you say to your patient that if you see anything extraordinary, if you feel something is wrong, just send me a picture. If we had this picture, if we knew that she has pain in the first few 12 hours, everything will be easier for me. I apply the hyaluronase and it will be easier. But as she has told us that pain late, then we have a worse healing of the area. Okay, blindness is the rarest but the most frustrating vascular complication, and until 2020, nearly 150 reports of blindness has been reported following fillers. Most of them are not related with HA fillers. Most of them are related with fat injections. This is a known thing. And 50 is reported to be related with the HA fillers. When we check the area, nowadays, we can see that the most common area is the nose area, and the others are glabella area and glabella in total with knees. So nose and glabella areas are the most common and most important areas for blindness. Yeah, we know it. Everybody see these slides before. It's like with the retrograde injection. And so it comes from here in retrograde way. It enters the central retinal artery and it causes an occlusion. what happens, what you might do? First of all, stop everything. And then they advise you to breathe the patient in a paper bag because a CO2 increase can lead to the retinal artery vasodilation. In simple cases, this might work. Give aspirin for further prevention. Also, sublingual nitrates for vasodilatation can be used. It's said in the some articles. Also, mechanical ocular massage can be done. And then you have to transfer this patient to a specific specialist that can do the hyaluronidase just around the central retinal artery. You will have 90 minutes before the retina is irreversibly damaged. It's the time. It's suggested to take immediate baseline retinography when you refer the patient to an eye specialist. And generally, they apply for the eye specialist to apply the 500 milligrams of IV acetylazamide for vasodilatation and to decrease the ocular pressure and help emboli to move. Sometimes the specialists can do anterior chamber paracentesis to make the pressure less on the artery, and also they can use timolol drops to make the make the ocular pressure less. Also, mannitol in some cases can say that can help the emboli to move, but we don't have any proofs for these are working. The problems with that and in the articles that can be found in the PubMed or other Cochrane libraries or other articles, it's said that injecting the 1,500 international units of hyaluronidase area around the central retinal artery may work. Because of even you are not in the directly in the artery, in some areas around central retinal artery, it can diffuse from the surrounding tissues, but it's not so clear that this mechanism is really working. Retrobulbar injection can be done just inside the eye, in the lower part of the eye, or inferotemporal peribulbar injection can be done, but I don't think that a normal routine specialist can do these injections. Maybe I can do the retrobulbar injection. Well, when I think of it, I'm trying to find in my setup, I think that I have found an eye specialist, and if I have this problem, I will take the patient to an ambulance and will go with the patient to that eye specialist, and I will want them to do the retrobulbar or infratemporal peribulbar injection. So just before having this complication in an area, for example, in Cairo or in other cities, maybe the dermatologists or plastic surgeons can find 1, 2, or 3 eye specialists, and you can talk about this complication might happen one day. And so if it happens, you will have the plan how you will deal with those things. This is a major review for retrobulbar injection. These were done. Some of them say that improved activity, no improvement after 48 hours. Worsened activity, no improvement, no improvement, no improvement, some improvement, no improvement. In New Zealand, animal models, these are. And one says some improvements. Also, there are also some risks for the retrobulbar injections, like hemorrhagia, orbital penetrations are so. Infratemporal artery, infratemporal area is the narrowest portion of the central retinal artery, so it's easier for the hyaluronidase to enter it. Theoretically, it might work, but more experience is needed. Selective angiographies were tried, but nowadays they do not say that there is no confident data for retroperfusion, and there are risks of the cerebrovascular hemorrhage also. This seems very logical for me. Supraorbital or supratrochlear notch injections, just going, Goodman and Clock offered, just enter to the supratrochlear notch area with a needle, just pierce the central retinal supratrochlear artery, and by this same mechanism that the filler reached to the central retinal artery, maybe we can do a retrograde way to reach the clot in that area by just directly giving in supraorbital or supratrochlear notch. And they have presented a restored blurred case, a vision case in this article, and also another author also presented the restored blurred case by the same application. Generally, in these cases, we can see that only 20% received full vision and 80% complete vision loss and partial vision. So, to summary, although we are experienced enough, there is always anatomical variation. They might affect our safety. So you might be unlucky one day, and we will have to learn how to deal with our complications. These are the forms that we use in Teoxan. If we have an adverse reaction, if you tell the, especially the team for the fillers, so we will also help you to get rid of those events too, and also we will see how the fillers react in those regions, so we can maybe do some developments in the fillers also. Thank you for joining us in this thing. And now, Doctor, these are our social media pages, so maybe you can follow us also for more detailed information. You can contact us from direct messages whenever you want also. Now, Dr. Amin also will show some good, interesting slides. And now I am stopping my screen share and passing to Dr. Amin.
Yes, thank you, Dr. Ismail. But before starting to show some of the interesting cases, I just want to, I want you to, so we can answer some of the questions.
Sure.
Received. I have the first question, and it's stating, what's the period time that it's allowed to use the hyaluronidase? The period of time that I can use the hyaluronidase after the injection?
Of course, every tissue can handle the ischemia for different times. In skin, it's longer. In central retinal region, it's very short. In you know, nervous tissues are very cannot tolerate the ischemia well, but the skin can tolerate it. First of all, as soon as possible. Of course, we have to do it, but it's not even late. Even after 3 days, you can apply it. You shall try your best. After 3 days, yeah, you will have less chances, but we have applied it in the case that I showed you 2 days after, and it still works. Even it's 1 week after, I shall try it and I shall use it.
Even if we have a nodule or something like this after that appears after 1 month, we can use hyaluronidase.
Yeah, you can try it. You can try it, and then because we have some weapons, we don't have too many options. We have some limited options, but you have to use it when you can use it, if as soon as possible.
Okay, another question from Dr. Naveen Durgam. It's a very interesting case. She's asking about the small unseen nodules, which we can feel them, which appear 4 months, 3 months after the injection, with associated with the episode of inflammation, edema, that come and goes every month or every 3 months in a place which is injected. So when she is asking, when she use hyaluronidase with antibiotics, it's resolved. But what happened? What's the problem? Is the filler, or it is microfilm? I think this is a case of microfilms.
Yes, I totally agree with you. I think this is a case of microfilm. Yeah, you think that it is depressed by.
I'm sorry, can we discuss? Can you explain for the audience what's the microfilm?
Okay, the thing is, we have some bacteria. We send some bacteria with the filler to the area, okay? And they stay silent in most of the time. But sometimes when we have infections, when our, for example, inflammatory capacity decreases, and sometimes when we have some upper respiratory tract infection with some bacteria, they cross-react with each other, because these are also known as, do you know that these are the products of the bacteria. So there are some cross-reactions with the fillers, and so then it reacts again, it goes away. My advice is, if a nodule is not palpable or is not, it's palpable but it cannot be seen from outside, don't push it and don't try to solve it. If the problem is just palpating it, just tell the patient that if you do not play with it, it will be resolved better. If you play with it, and then you might have a rupture with the kyst area, and then the microfilms can lead to bigger reactions. So if there is no presentation of any symptoms, don't do anything. That is my advice.
Me too. And with these patients, I give them low antibiotics like vibramycin for a very long period, because it has also an anti-inflammatory effect. So it really has a beneficial role in these cases with their anti-inflammatory effect.
Yes.
The other question is from Dr. Ines. She's asking about when she inject the tear trough. Sometimes after 1 month, she finds that the tear trough comes again, and there is no sign of the filler in the tear trough. So she's asking about the migration in the tear trough. What happened? What really caused the migration of tear trough? This happens a lot of time, that we see that after injection the tear trough, everything is gone after 1 month or after a couple of weeks. So what about the migration in this area?
Generally, it might be, first of all, related with the product. Sometimes really the products are to make the reactions less, and some firms make the product very thin and very low amount of cross linkages. And then when you apply it under the muscle, of course, just under the orbicularis oculi muscle, sometimes even the muscle is has a low activity, but with the movements, then it presses the area, and I don't think that it migrates, but it dissolves, and so it loses its effect. I don't think that everybody is asking, what about the superficial fat pads? What about the tear trough region? Do you think that migration can happen? With good products and with a good cohesivity of the product, I don't think that there will be a big migrations of the product if you apply it in the right plane. But generally the thing is not migration. I think that the problem is the edema, especially when people come with the malar edema. People say that my filler was here, but now the filler is here. I think that the filler is still there, but the edema has just stayed here because of the lymphatic drainage of that area. So if there is a problem in the malar region, we have to do the hyaluronidase in all area of the tear trough region, not in the malar area. If you just apply here, you will not solve the problem here, and so we will have in too much volume that we can handle. So we have to get rid of some extra hyaluronic acid in that area in these situations.
One more question. I loved your part of the presentation, Dr. Ismail, when you were talking about the vascular complication. It was very, very nice, very beneficial. The protocol of treatment was very good and was very up to date. I just wanted to ask you this. We have this question about the beneficial use of nitroglycerin patch in treating vascular complication, because there is a lot of new reports that doesn't recommend nitroglycerin patch, that it suggests that it makes the emboli migrate when they open the vessels to the place to cause more damage. I'm not convinced with this point of view, because in my patient I see a lot of beneficial results with the using of nitroglycerin patch. So what do you think about the nitroglycerin patch they use nowadays?
I still use it, first of all.
Yeah, I still use it too.
But the thing is, there is a problem with nitroglycerin patch. When we apply it, the patients generally complains about headaches. it really makes the patient's headaches, and so we have to tell the patient about that. Yeah, okay, it increases the vasodilatation in all around the body, also in the central venous system and the central nervous system, and also it leads to some redness in face, and also it leads to headaches. If sometimes some patients cannot tolerate these headaches, and we have to stop it. But if the patient can tolerate it, I think it's a good way to try. If the patient has headaches, then we can think that yes, we are successful in vasodilating the vessels. And if it works in 15%, 10%, it's something. Because even in sometimes it's like on the edge. You reach edge, and if you pass it, then you solve the problem. If you reach here, but you fall back then. So it will, if it will give you 50%, 15%, pardon me, sometimes 15% is even enough, and I still use it. But because of the side effects, some papers say that it's not, you don't have enough cases that show beneficial effects, but there are many reported side effects. So it's up to you, but I use it if you ask my experience as you use it.
Okay. One more question. You stated in your presentation that you use lansoprazole in the treatment. Why do you use it?
Because in my previous experience, everything is related with the experiences. Before, yes, in a patient that I used the corticosteroids, I had a gastric bleeding case. Okay. One of my cases had gastric bleeding. If you are using the corticosteroids in high doses, and if he or she has a pepticulus, then a gastric bleeding can start. So yes, I used steroids, and she had gastric bleeding, and she had endoscopy, and she asked me, why you use steroids in high doses, and everybody wanted me. So I had a bad experience. So I'm trying to have a prophylaxis with the gastric ulcer prophylaxis in these cases. Even I use non-steroidal anti-inflammatory drugs for a long time. I use something like ranitidine to make the gastric acid secretions less. That's the reason.
Okay, Dr. Ismail, so now we'll see some cases, and then we will come the question at a time.
Okay.
These are cases of angioedema. So we see these cases of angioedema, especially sometimes when we use the TIRTAF. So what do you think is the best treatment in the cases of angioedema?
For example,
steroids with antihistamine.
I use oral or systemic steroid in these cases, first
Yes.
of all, because I think local things will not work well. Yeah, you dermatologists know the treatments much more than me, so I think it will be better for you to give the exact doses. But if this was my case, I would start systematically 1 milligram per kilogram corticosteroids,
and then we taper.
Yes, and then we can continue it with oral steroids for 6 or for a week or so on.
Okay, and then sometimes we feel like there is a granuloma after the subcision, after the angioedema subside, and if I can feel a granuloma or I can feel a hard nodules, and sometimes with the pathology we find foreign body granuloma, like in this case. So what's the best treatment for the foreign body granuloma when there's an action with the fillers?
For these cases, if I can make the debridement, if I can get rid of the product by directly entering into the nodular area, I try to do it if there is a chance of small incision. But if the thing is deep, if it's is a very visible way, and then first I will try to do it with, for example, with a needle. I just go enter it, but before I warn the patient that even by puncturing with a needle, it might really cause a big biofilm reaction.
That's why we give them, you like to give them antibiotics before the procedure.
Yes, so one or 2 days, better is 3 days before.
Perfect.
We can start antibiotics and then do the dose puncture. Even be sure that by just small needles, you can cause big infections and big reactions because everything's hiding downstairs.
It's like you are exploding the biofilms to all the...
Yes, it's like a bomb and you have...
And you are exploding the bomb.
Yes.
So this is a case of vascular compression, and I think you stated very well that routine we do for the vascular compression. This is a case of a Tyndall effect with edema with the filler injection of the T-trough. I think that one of the main causes of the Tyndall effect is the superficial placement of the filler and of course the material. Can you highlight about the material to be used in the T-trough? Because this is very challenging to choose the material which is using of the T-trough.
The thing is, if the skin quality is low, then the patient demands more and more fillers, because when we apply some filler, they have some improvements. And patient looks, okay, we applied 0.5 cc and now it's 50% better. If you apply 0.5, it cannot be 80% better. It will be worse because there is a limit capacity for that filler to reach the maximum improvement. If the skin quality is low, I don't apply generally any superficial fillers. I apply superficial fillers if the skin quality is good, because when we apply superficial fillers, then we have these kinds of angioedemas, and when we push harder and harder to make it better, it becomes worse and worse by time. What about the filler type? Of course, it must be a specific filler. When you apply very thick fillers in superficial fat pads of these areas, then you lead to a great malar edema because it will have some edema capacity. The thing is, in these areas, the fillers must have some linked and some cross-linked parts. So non-cross-linked parts will just hydrate the area and but will go away by time, and then edema will come and there will be a balance with it. So I use Redensity just Redensity in these areas, and I don't use any more fillers. But with some fillers, it's not 𝐂𝐨𝐦𝐻𝐚 ones. I will not mention about the name of it, but I had really, after 6 months, after 9 months, I had swellings. No problem was there. It was the product that was produced for that area. It was introduced for that area. But 9 months later, some late onset reactions was experienced by me. So I use just Redensity in T-trough region, nothing more.
I think one of the main benefit of using Redensity 2 is that it does not absorb water like the other brands. Yes. So so what you see, it's what you get. You don't have. Yes. Another picture, and so the herpes, something with you, especially with lip fillers, that you see after injection the fillers, there is an outbreak of herpes. So do you give your patient antiviral therapy as antiviral therapy before injecting the lip filler? Either way, it's a prophylactic antiviral, or do you select some patient when they have the history of viral infection?
Yes, that is a very good question. Really, I have faced herpes infections. And so in our, when patients are calling us for lip fillers, my assistant asks them, do you have often herpes infections in your lips? If they say that, yes, I have herpes infections, for example, 3 times a year, twice a year, then we say that an ointment and antiviral treatment just 1 day before, we prescribe it and send it to the patient. and just 1 day before we start the prophylaxis and use it for 3 days. And I use Valtrex. I cannot remember the name of the material inside it, but I use the product, I prescribe it, and one
Valcyclovir, yeah, it's for Valcyclovir. Okay.
Yes.
Our last picture, I want to show it to you, Dr. Ismail. It is this patient. The patient, which I have a couple of patients like this, using non-biodegradable filler or permanent filler 20 years ago or 25 years ago, and now they come to the clinic with these strange hard nodules. The problem here that all the surgeons refuse to do the surgery to evacuate the nodules because they come back every time and then these nodules experience some inflammation and some biofilm formation too. And then we treat them with corticosteroid, we find there is a lot of, there's atrophy between the nodules. So this, I know this is a challenging case and it's hard to treat, but what the best you can advise?
First of all,
I sometimes use the combination of 5-FU with steroids.
Perfect.
5-FU with steroids with long duration using the antibiotics like clindamycin, vibramycin. I use it for a very long period with ciprofloxacin. But what do you think? What we should do with these cases?
If possible, I will try to get rid of any kinds of injections to these patients. It will burst. Yes. It can burst, and so if I will do it, I will have a good
inject this patient. I'm sorry, Dr. Ismail, you said
I will do it, but I will have a very good consent form.
Okay. Very good. Very nice.
It will really create a problem, and I don't have any responsibilities for example, sometimes if a reaction happens, and if she's hospitalized for example, 30 days, who will pay the hospitalization fees?
Yes.
It's also a problem. And she may demand something that, and if something bad happens, before everything, they say that, oh, doctor, please help me, please take these things, I can do everything. But after a bad thing happens, they will say that, no, you were the doctor and you don't have to do it. It is your fault, and the fault will be yours. So please be sure that you will have a good consent form for that. If you will have this, nobody can earn any money from these cases. This is the responsibility of being a doctor. I treat them. It's because of I really don't earn anything from these patients. I try to help them as a doctor.
Yes,
but I find them, and these are really challenging cases, and I don't want any of my colleagues unexperienced. If you're not experienced enough, if you don't have a big name, then the patient will really put a lot of pressure on your shoulders.
Of course.
The problem. If you are a big name, then your name may cover some problems, and they will say that, okay, I go to a big name, but it happened. It is a rule, but if you're not, it will be a hassle for you.
I just want to add that some of these cases, they come to re-inject filler. They want to inject filler. So my advice that these patients, sometimes when you inject them with the filler, you start to make the bomb explode. When a needle comes to this patient here for injecting Botox or even fillers, biofilm starts to react again. So my advice, if you really have to inject these patients, they have to be covered with antibiotics 1 week before the injection.
I totally agree.
Right. So I have one last case. It is this case with a nodule that when was treated with steroid, it did atrophy when the skin around it. So what do you suggest using the corticosteroid when we have hard nodules? Do you use the steroids, how we dilute it? And we use steroid with the 𝐂𝐤𝐬𝐧 or not with the 𝐂𝐤𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬
hyaluronase. If
Iodase.
it is not working, then I dilute the corticosteroid with 1:1 or 1:2, according to the area that I will apply.
Very
And
nice.
do not give the steroids very close to superficial areas of skin. Just if you will give into the nodule, just try to give the steroids in deep parts of the nodule. If you stay superficial, these problems will be more, and you know that there will be lightening in the skin. You will lose some pigment also. You will lose some fat. Your skin will be thinner. So if you're using the steroids, please stay as deep as possible. I can advise. Yes, I use
as deep as possible. I have one question that was asked a lot of time about the side effect of hyaluronidase. What are the side effects of hyaluronidase?
Yeah, we theoretically know that the hyaluronase also can lead to some severe allergic reaction. Yes, I haven't experienced it. Maybe I'm lucky, but of course there is always a risk of acute allergic reactions. Even it can lead to some obstructions in the airway also, hypersensitive to reactions. So we will have some drugs that, and we have to have some emergency precautions for that. First of all, this is the first thing. The second one is it might lead to some simple allergic reactions also. When we apply the hyaluronase to an area, generally the area becomes ödem. The edema increases in those areas, and the patients are really panic in the first day. So we have to warn the patients that the edema might increase in the first hours after we apply the applications. And also the other risk is it is really a painful application. Hyaluronase applications are really painful. So we might use some local anesthesia to get rid of the pain of the fillers in these cases.
I want to share my experience with the hyaluronidase, Dr. Ismail. I've seen two cases. One of my cases when I used the hyaluronidase in the lip, that they developed severe angioedema. And it was a matter of 15 to 20 minutes. They developed severe angioedema, and I was treated with corticosteroid 1 milligram per kilogram for 3 days. Then everything went. So we have to be aware of this. Other question was about the biofilm, Dr. Ismail. What is what the best treatment or protocol we should be used for prevention and for treatment of biofilm when we have?
Okay, the best prevention is doing the injections as sterile as possible. Of course, sometimes we don't give enough importance to using antisepsis before at the area of usage. So first of all, clean the area with a good antibiotic, antiseptic solution, and use sterile gloves, and try not to touch anywhere with your needle or cannula, so you will not bring any bacteria to the areas. Also, you have to use good products to be sure that the product even itself do not have any bacteria inside because of the production thing. What about if it happens? The best solution is not touching the biofilm and do not entering the area and just let it sleep. Okay, but if we have to get rid of it, if we can palpate it by directly just entering with an incision, just with some healthy tissues around it, we can excise it surgically, of course. Or as we discussed before, we will have to start some antibiotics before, and then we will try to use some local treatments, but first prophylaxis, and then do it. If there is no symptoms, do not play with nodules or other things if the patient does not complain from it. I don't think that this is enough. I can feel it. No, it's not a reason to touch it. You can treat it if it makes an visual problem, but I can palpate it here. Okay, never mind, and don't touch it. I had fillers. I filled it, for example, for 2 years, but I did nothing, and after 2 years, it's gone. But if I played with it more and more, it might lead to some reactions for me.
Very nice, Dr. Ismail. Thank you very much for this. And I would like to thank you when the video you show in your presentation was very nice about injecting and doing incision and drainage of the biofilm with when you squeeze it and then you remove a lot of it. I find this, it's very helpful. I did it a lot and it was very, very helpful. You showed it very well and now you explained how to do it with caution. Our last question before we end, we need to know when you use hyaluronidase again, what's your preferred dosage of dilution for the hyaluronidase when you are treating a patient with vascular complication with hyaluronidase? So how you dilute it and you inject it how many times? Okay.
The thing is, everybody asks what's the maximum dose of the hyaluronidase. First of all,
yes.
I don't know.
And does it affect the normal tissue?
Yes, it does not affect the normal tissue. First of all, it's just to get rid of the hyaluronidase and hyaluronic acid bones, to get rid of those bones. In some presentations, in some articles, I saw that they used up to 6,000 units in some cases in areas, for example, for blindness. So that means that for vials, but in my practical, in clinical practice, I use generally 1 vial for an area in 1 day. It leads to 1,500 units. It's like that. And generally for 1 ml of area, I use like 300 units of reductase for the area, but you can use more, but at least for 1 ml, you have to use like 300 units or so. I apply generally if the area is big. In 3 times, I dilute it. For example, if the area is big, I will dilute it for 3 ml and I will use 1 ml in 1 hour. And in 1 hour later, I will use again once more. So 3 times in 1 day. In total, 1,500 units. I mean 1 vial in each time. But you can use sometimes 2 vials if the area is big, or up to 6,004 vials, but I don't know any study. If you have, please share with me. I don't know the exact upper dose for hyaluronic acid that might lead to toxic doses.
Yes, actually there was no study stating a maximum dose like you were just explained, Dr. Ismail, and we usually, all the recommendation is to use hyaluronidase even sometimes every 2 hours till we find that the skin went away. And sometimes we use it every other day or every day till we find that there is another capillary refill or the vascular occlusion is ended.
Yes.
Dr. Ismail, I would like to thank you very, very, very much for your valuable, as usual, your very informative and lecture. It was a great honor for us to have you today. We loved your presentation. We had a lot of questions and all the audiences are really appreciated what you did today with your lecture. Thank you very much, and I will send the other question that we couldn't answer. I will send the answer via email, inshallah, in the next coming days. And we would like to thank you very much, Dr. Ismail, for your valuable presentation.
Okay. I want to thank you for inviting me. It's my pleasure to be with you. And in the future also, when you want me to come or want me to do a presentation, it will be my honor to be with you again in the presentation because it's a very good and a well-organized meeting. I know Sham Dharma and the reputation of the Congress is very high one, and so it's my pleasure to be with you, and thank you again for inviting me.
Thank you, Dr. Ismail. You're always welcome, Sham Dharma. Thank you very much.